Hello there again, this is Cameron Bhopal and we're here with another emergency scenario on metastatic spinal cord compression. So your scenario is a 67-year-old gentleman with acute urinary retention, unsteady on his feet for the last few days with niggly lower back pain. PSA done was 204. What is your most likely diagnosis? So you end up saying, with acute urinary retention, back pain and neurological symptoms and a PSA of 204, I'm most concerned about metastatic spinal cord compression secondary to prostate cancer. How would you assess this patient? I will take a focus history and do a clinical exam trying to ascertain the cause of his neurological symptoms. Sometimes they would say, what questions will you ask in history? You end up saying, I will ask for the onset, duration and progression and severity of his symptoms, and also lower urinary tract symptoms including storage and voiding symptoms, associated UTI symptoms and any red flags such as hematuria, weight loss, nocturnal enuresis, anorexia, and associated back pain, lower limb weakness, gait abnormality, paresthesia, numbness in the lower limbs, bladder and bowel dysfunction, any known prostate cancer, otherwise risk stratify according to age, ethnicity and family history of prostate cancer, and medications such as anticoagulants, allergies and general fitness and performance status. Obviously this is an emergency scenario, so you have to keep your history short. And then they say, how will you examine this patient? So I will do a general examination looking for gait, cachexia, shortness of breath at rest, general fitness, abdominal exam looking for impalpable percussible bladder, flank pain or abdominal masses, DRE to look for obvious signs of malignancy, anal tone and saddle paresthesia or numbness, and neurological exam to looking particularly at spine tenderness, power, reflexes and sensations. Then what investigations would you organize? Full blood count, USANEs, LFTs, calcium and a repeat PSA. Ultrasound KUB can be considered in AKI if high pressure chronic retention is suspected, and importantly the MRI of the whole spine needs to be done. So MRI whole spine is quite important if the patient's having lower back pain symptoms. They would usually give you something, lower back pain and has got some paresthesia in the lower limbs. Oh yeah, so MRI of the whole spine. So they'll give you a heads up about, this is actually neurological symptoms related to the PS of 204. So it's quite obvious. Okay, so, they can then show you an MRI picture and you can see it in some of the interview notes. There's many out there, but, of metastatic deposits. So you just have to say that this is a, whether it's a T2 image and whether this is a sagittal image or whether this is a coronal image, and what does it show, what level the lesion is at. Usually it will be a sclerotic lesion and it's pressing the spinal cord. These are the important findings you have to say when you're explaining the scan. What are your next steps? So next steps after you've seen the MRI scan which has shown all of these findings, the patient needs to be nursed flat with spinal alignment. I will let the on-call consultant know, and the urology CNS to acquire Degarelix 240 milligrams subcutaneous stat. We'll call the metastatic spinal cord compression team, including spinal surgeons who may consider spinal decompression based on his performance status, and also the acute oncologists who may recommend steroid treatment with dexamethasone, usually 8 milligrams twice daily, and consider palliative radiotherapy urgently. I will also add to my MDT where they may consider further scans, biopsies and novel treatments, and update the family about the progress. Then comes the question about principles of management. The principle of management is reducing edema around the spinal cord and stopping the progression of prostate cancer. What are the consequences of tumor flare? Important question there. So it can cause bone pain, further compression of the spinal cord, acute urinary retention, ureteric obstruction, and due to the hypercoagulable state, it can also cause a stroke. Then what is the mechanism of action of Degarelix? So Degarelix, I've explained it in my previous video. So Degarelix is a GnRH antagonist. It blocks the GnRH receptors at the level of the anterior pituitary and completely blocks the production of LH and FSH into the bloodstream, which is responsible for production of testosterone from the testes. So if it's blocked, no testosterone will be produced, no dihydrote will be produced, and henceforth no prostatic growth will take place. Okay, so that's the end of this station, and I'll see you in the next station, which is a trust biopsy sepsis station in emergencies. And I'll wish you the best and hope you all get a national training number.